थोडंसं ना काम करतो.
Acha, you
Sir,
are not in Baroda.
no, sir, I reached today only. I got
Acha, you
I
reached
just
today.
forgot to inform you. Like
Okay,
last moment મને રિઝર્વેશન મળી ગયું તો પછી થઈ
okay,
ગયું. હા આજે
fine,
સવારે.
fine.
Yes, sir.
બરાબર, right. Okay.
Yes, sir.
તો હું 5-1 મિનિટમાં આવું છું. હા,
હા સર ભલે. હા સર. હા હા. Yeah. So namaste. Good evening, everyone. So today we have Santhanam sir with us, and it's pleasure to have you, sir. There's a lot to learn from you. Highly experienced, and so many awards he has won. It's a big and very, I will say that inspiring. CVs sir has shared with us, and but I will just give a brief introduction. So sir has done BA and he has done PhD in the field of psychology. He has also done DCMH from Enhance and FINSP. And he's a very renowned figure in the field of psychology, and he has also done PGDCH. And today, sir is going to present his case, and we are very happy to have you, sir. Thank you, and over to you.
Thank you, madam. Thank you very much. At the outset, I want to dedicate this presentation to my hypnotic guru, Dr. Palan sir. Whatever work I am doing, actually, I wanted to dedicate to my hypnotic guru, Dr. Palan sir, and Dr. Nivedita madam, my friend Dr. Raju from Hyderabad, and Bhavani madam, of course, she is my senior, of course. Nivedita madam also my senior, and other colleagues and other associate. It is my great pleasure to share my clinical experience in this platform. My topic is concerned, it is little bit, 1 minute. And I'm sharing, actually, I want your request. Allow me to share. You have to allow me for sharing my PPT. Yeah, it is there. Now it has come. Okay, don't do it. Yeah.
Done?
Yeah, it has come, madam. Thank you.
Yes.
Now, the title of this presentation itself says that it is an exploration, exploring hypnosis to help overcome orgasmic dysfunction. So here, exclusively, I have not used our clinical hypnosis for treating this orgasmic dysfunction. Beside our clinical hypnosis, I have used other techniques also. So that is the reason why I have given the title as a exploring hypnosis to help overcome orgasmic dysfunction. So hypnosis, of course, I have done a lot of, I have collected a lot of review of literature also in this aspect. So from that point of view, just I am presenting, hypnosis can be an effective therapeutic tool for overcoming orgasmic dysfunctioning by addressing the underlying psychological and emotional factors that may contribute to the condition. Through guided relaxation and focused suggestions, hypnotherapy helps individuals reduce anxiety, reframe negative beliefs about sex, and overcome past trauma or performance fears that may be inhibiting orgasm. So here, what is the orgasm? Of course, everybody knows. However, I am going to just briefly define about this OD. Orgasmic dysfunction characterized by the persistent inability to achieve orgasm despite adequate sexual stimulation. It's a common sexual health issue that affects both men and women. In recent years, several studies have explored the prevalence, causes, and the treatment option for this condition. The DSM-5, according to the DSM-5, orgasmic dysfunction classified under sexual dysfunction disorder in the DSM-5, that is known as a Diagnostic and Statistical Manual of Mental Disorder, 5th edition, refers to the persistent or recurrent inability to achieve orgasm following sufficient sexual arousal and stimulation. Despite the desire to do so, it is considered a significant concern when it causes marked distress or interpersonal difficulties. The disorder is further divided into two categories. One is female orgasmic disorder and male orgasmic disorder, which is otherwise known as delayed ejaculation, based on gender differences in presentation. In female orgasmic disorder, this actually the female orgasmic disorder I have taken. I have worked with a lady, a young lady. Women experiences marked delay, infrequently or absence of orgasm during sexual activity despite adequate sexual stimulation. According to DSM-5 criteria, a presence of either of the following symptoms and experienced at almost all or approximately 75 to 100% occasion of the sexual activity in identified situational context or if generalized in all contexts. Marked delay, they are actually postulating two major symptoms. Marked, marked delay in marked infrequency or absence of orgasm, markedly reduced intensity of orgasmic sensation. The review of literature, I have referred some recent review of literatures also. Orgasmic dysfunction is a significant concern for both men and women, though it is more commonly reported among women. During 2023 study by Smith et al. Reported that approximately 10 to 15% of women experience persistent orgasmic dysfunction with higher rates among women aged between 18 to 35. For men, rates of delayed or absent orgasm tend to be lower but still relevant, with the prevalence ranging from 2 to 5%. The general population as reported by Johnson et al. During 2022. There's another study by Fitzgerald et al. 2023 found that impact of orgasmic dysfunction on relationship satisfaction and overall quality of life is substantial. Women with orgasmic dysfunction were more likely to report emotional distress, lower self-esteem, and a diminished sense of sexual satisfaction, leading to relational strain and a decreased sexual confidence. Recent research has also investigated the use of hypnotherapy for treating orgasmic dysfunction. Stewart and Thompson during 2023 conducted a pilot study on the use of hypnosis to address orgasmic dysfunction, particularly in women. The study showed promising results, with the participants reporting improved sexual arousal and orgasmic ability following hypnosis sessions designed to address underlying emotional issues such as performance anxiety, and a fear of intimacy. See, this is the case history. Actually, the name of the client is T. Her name is different. Just don't want to mention her name. The age is 21 years, married, status married, chief complaint. When she came to my clinic, she has been brought by her parents. The chief complaint was difficult to attain the climax during sexual intercourse, lost interest in indulging in sex. She is a MBA English graduate. Onset of symptoms problems since marriage, immediately after the marriage. Marriage has taken place 1 year back. Duration of symptoms problem for past 6 months. Associated disturbances. Presently having depressed mood. Diagnosis orgasmic dysfunction. So based on this information, of course, we have collected other information also, but actually whichever is relevant for our presentation, only those information I have taken. Patient is 21 years old woman, recently married, presents with the symptoms of sexual dysfunction, characterized by a lack of sexual desire, difficulty achieving orgasm, and anxiety about intimacy. Presently having depressed mood, she reports no interest in initiating sexual activity and experiences minimal sexual excitement or pleasure during intercourse, despite a harmonious relationship with her spouse. I called the spouse also in order to collect some more information. He also very much cooperated with me, and we have worked. I mean, actually, I have made all these things for both, not only for her, even for her husband. Although she is receptive to sexual advances, she experiences little arousal or sensation, both genital and non-genital, during intimate encounters. While she shows mild sexual arousal in response to external visual cues, this does not translate into arousal with her spouse. Patient expresses a mild anxiety around sexual activity, indicating a need for more time to feel comfortable engaging in intimacy. Her symptoms are very well fit into the orgasmic dysfunction as per DSM-5, where it indicates a notable delay in reaching orgasm during sexual activity, a marked infrequency of experiencing orgasm during sexual encounters, an absence of orgasm during sexual activity. Further, our symptoms suggest a psychological or emotional barrier to sexual engagement, likely rooted in fear of intimacy or emotional resistance to sexual involvement. Patient does not report guilt, shame, or relationship issues, but her anxiety and lack of readiness for intimacy indicate underlying psychological factors such as low sexual desire and fear of vulnerability. Now, the treatment was focused on addressing these emotional factors through sex education. Sex therapy, developed by Masters and Johnson, it was a very famous, what I can say, treatment procedures pronounced by Masters and Johnson during 1975. They have written a beautiful book called Sexual Inadequacy. Those days, all the psychology students as well as the psychiatrists compulsorily they used to read the book. The name of the book is Sexual Inadequacy, authored by Masters and Johnson. And hypnotherapy, relaxation techniques, and gradual desensitization to sexual stimuli, building body awareness, reducing anxiety, and fostering a supportive environment for sexual exploration with their spouse. Working on both individual and couple dynamics in a therapeutic setting can help patient overcome her sexual dysfunction and develop a healthier approach to intimacy. These are the following recommendation, and based on this, I have prepared the schedule for the treatment. Number one is sex education, sex therapy, genital and non-genital sensate focus, procedure for specific sexual dysfunction, clinical hypnotherapy, and interventions. The following steps for sex education recommended to follow. A phase at which the women proceeds should be directed by how comfortable she is with this program, because since the male therapist is working with the female patient, first of all, we have to see ethical point of view and whether she is very much comfortable with the male therapist. And of course, I obtained her consent, and similarly, I obtained the consent from her husband also. Not by a rigid schedule. At each stage, the woman's attitude to work, to what she is being asked to do, and what she has just done must be explored. Further cognitive work may be needed if highly negative attitudes are identified. General self-examination. This comes under sex education. This self-awareness exercise may be especially helpful if the woman has any negative attitude to her body. She should examine herself generally while naked and identify three aspects of her body she likes, m- mind three which she likes less. This attitude to her body should be explored in the next treatment session. The aim is to get women in touch with her body and help her to develop a rational appreciation of it. Genital self examination, visual examination of genital using a mirror, identifying various areas that have previously been pointed out on a diagram by the therapist, followed by exploration of genitals with her fingers both outside and inside. Pelvic muscle exercises, masturbation, genital stimulation to produce sexual arousal with attention focused on erratic experiences or sensation. Adjuncts to masturbation, the following aspects are suggested in order to enhance sexual arousal. That is, number one is erratic literature. Sexual fantasies, of course, it has been proved by a research study, can help women who do not find it easy to have fantasies. Then vibrator, if orgasm not occurred after several weeks of regular masturbation. Anxieties about using one, especially of becoming dependent on it, must be discussed about whether she is very much comfortable of using vibrator. Most women who become orgasmic with a vibrator are soon able to reach orgasm without it. Non-genital sensate focus. This was developed, as I mentioned, this was developed by Masters and Johnson during 1970. Non-genital sensate focus. This stage is beneficial for most couples with sexual dysfunction due to anxiety or pessimistic attitude resulting from repeated failures. Before describing the initial assignments, the therapist should explain the aims of this stage, namely to help the partner to develop a sense of trust and closeness, to become more aware of what each likes, and to encourage communication. The couple are first requested to refrain from sexual intercourse and the touching of each other's genitals and the women's breast. It should be explained that this is to ensure that they are not continually confronted by this aspect of sexuality, most likely to cause anxiety, to enable them to concentrate on rebuilding their physical relationship by learning to enjoy general physical contact. During the following week, one partner, when he or she feels like it, should invite the other partner for homework session. This invitation should be explicit. Example, I would like to try the caressing that the therapist suggested. Would you? and the other partner should accept the invitation if he or she is feeling either positive or neutral about it. Feeling negative, it is important that partner says so but tries to explain why. These instructions are intended to open for communication and avoid partners feeling pressurized by each other. The caressing sessions can occur wherever the couple wish, as long as they feel comfortable, warm, and there is no risk of them being disturbed. The eventual aim might be for the partners to be naked during the session with some low lighting in the room. Non genital sensation focus should begin with one partner, the one who gave the invitation during the homework, exploring and caressing the other partner's body all over, except the no go area. The partner should do this in a way that gives pleasure to both of them. The other partner should try to concentrate on the sensation elicited by the caressing or provide feedback on what he or she likes or dislikes, and how things would be improved. Example by Homer, lighter, slower, or faster. Guiding the partner's hands can be a good way of doing this. During the early session, this exercise may often be like a massage. The partner should swap around when they wish to, so that the passive partner now takes over caressing. The session can go on as long as the partners want it, usually between 10 minutes to half an hour, but they should avoid becoming bored. Sexual arousal is not the objective at this stage, but if other or both partners does become arousal, they are encouraged to enjoy this but not go beyond agreed limits of caress. Some people find that a lotion, a KYJ jelly or baby lotion enhance the pleasure of sensate focus. There is no restriction on masturbation. Should either partner wish to relieve sexual tension, it should be restricted to self masturbation, not in the presence of the partner. Reaction to non genital sensate focus. Initial reaction to this stage vary according to the nature of couple's difficulty. Some couples immediately find non genital sensate focus enjoyable, others initially react negatively. And a report, for example, not having enough time for homework session, breaking the ban on sexual intercourse, negative feelings like tension, boredom, one partner being unable to offer an invitation. Then the next stage is genital sensate focus. Aim, aims of this stage should be explained to the couple, namely to make their caressing more sexual and arousing, but also to encourage them to continue discussing their feeling and desires. To begin with, the couple are asked to continue their pattern of alternate invitation and taking turns at caressing, but extending this to include both partners' genitals and the women's breast. Now, the partner should concentrate on the relaxed giving and receiving erratic pleasure. If aroused occur, then it should be enjoyed. Guiding the partners and can again be useful means of helping the partners learn what is enjoyable. Lotion also can also be used at this stage if couple wish. When this stage is progressing, well, the couple are instructed to include mutual caressing as well as taking turns at being active and passive. Should either or both partners wish to experience orgasm, they should feel free to do so, but this should not be become the goal of the session. Reaction to genital sensate focus. This stage is particularly likely to generate anxiety, especially about sexual arousal or intimacy. Therefore, the therapist specifically encourages the partner to focus on pleasurable sensation. Procedure for specific sexual dysfunction of women. Where women has never experienced orgasm, masturbation training might be considered because most women find it easier initially to experience orgasm on their own. However, while this approach is a treatment of choice for a woman who does not have a partner, many couples will prefer to try to resolve the problem in the context of their conjoined sexual activity. A woman who can experience orgasm on her own should be encouraged to show her partner how she likes being stimulated. Hand on hand guidance being good means of doing this. The therapist should emphasize the importance of clitoral stimulation for female orgasm. If a woman is unable to reach orgasm in spite of apparently adequate stimulation, a vibrator might be suggested by wife Iffy and Fenwick during 1986. It is important to reassure the couple that this need only be a temporary measure. The therapist should also discuss the range of female orgasmic responsibility, emphasizing that many perfectly normal women experience orgasm on only some occasion of sexual activity, but that sex for them is nevertheless extremely enjoyable and rewarding. Once the orgasm is possible with manual stimulation, a bridge molecule that is that study has been done by Kaplan during 1987 can be used to help women become orgasmic during sexual intercourse. The partner or the woman herself should provide clitoral stimulation manually during the vaginal containment, combined with slow pelvic thrusting by the woman. When she feels herself approaching orgasm, she should begin vigorous pelvic thrusting and continue to obtain clitoral stimulation, if possible, by pressing her clitoris against her partner's pelvic. Some women will eventually be able to experience orgasm during sexual intercourse without manual stimulation, but many will continue to need clitoral stimulation. Whatever the outcome, the couple should be reassured that either is perfectly normal. So here, yeah, I have used the clinical hypnosis intervention. Say, for example, each session I have conducted. Initially, I have given breathing awareness, progressive muscular reaction, relaxation, then BA and PMR, ego strengthening, PMR, sensory imagery conditioning, PMR, dynamic imagery conditioning, then illustrative suggestion in sex therapy, suggestions for facilitating sexual fantasy during the trance. All these things I have done during the when they are in trance, when she was in trance. Metaphors for going out to dinner and back scratching. Suggestion for ejaculatory inhibition or orgasmic dysfunction. Patient represents a complex combination of emotional, psychological, and interpersonal factors contributing to her sexual dysfunction, particularly orgasmic dysfunction and sexual anxiety. Despite the lack of significant relationship issues, her symptoms such as lack of sexual excitement, difficulty achieving orgasm, and fear of intimacy suggest that underlying the psychological factors, including anxiety and a possible fear of sexual intimacy, are significantly influencing her sexual health. The conclusion is concerned. The treatment outcome was positive, with the patient showing marked improvement in her sexual functioning and emotional well being through comprehensive approach involving sex education, sex therapy based on the Masters and Johnson model, hypnotherapy, relaxation techniques, and a gradual desensitization. That patient was able to overcome much of her sexual anxiety and a fear of intimacy. Her ability to achieve sexual arousal and orgasm improved progressively, and the supportive involvement of her spouse played a key role in fostering emotional safety and open communication. Hypnotherapy and therapeutic guidance helped her develop a more positive body image and a greater sexual self-confidence. Overall, the intervention not only alleviated her symptoms but also contributed to a more fulfilling and a satisfying sexual relationship. With the continued gains sustained over time, periodic follow-ups are advised to maintain progress and to provide ongoing support. The feedback. I have taken the feedback from both the partners, from the couple. Following the intervention, the patient reported significant improvement in her ability to achieve orgasm during sexual intercourse. Actually, her husband also acknowledged the same, a change that was also acknowledged by her husband. This progress reflected the effectiveness of the comprehensive therapeutic approach, which included sex education, sex therapy, based on the Masters and Johnson model, hypnotherapy, relaxation technique, and a gradual desensitization. The patient's positive responses indicates a successful reduction in sexual anxiety and enhanced sexual responsiveness, contributing to a great intimacy and mutual satisfaction within their marital relationship. These are the references I have made. Thank you very much. Thank you very much, my participants, those who have actually listened very patiently. If you have any doubts, let us discuss.
Santhanam sir, can you please remove this presentation now
So, yes, sir.
so that we can have gallery view
Yeah,
and we can see each other?
yeah. Yes, sir. Thank you, sir.
Good. So, very good case and very naturally, Dr. Santhanam, when he presents in a very scientific manner. So, thank you very much for
Thank you, sir. Thank
this
you, sir.
presentation. It was really a learning experience for all the students, including myself also. Good. Please, any comments? Yes, please. Please check the sheet.
Good
Check the
evening.
sheet.
Good,
Good evening.
good evening, Santhanamji,
Sir, good
Balan
evening,
sir.
sir.
My
Good evening.
my due respect, sir. Sir, it was undoubtedly it's a very good topic, and we learned a lot. One thing I wanted to know, sir, by profession I am clinical psychologist, and sexuality is my forte, and I
Oh,
dealt the woman with orgasmic dysfunction. Over here, you said about that Masters and Johnson techniques.
correct.
So my one question was that for genital and non-genital,
Sir.
it was very much applicable in Indian scenario with this couple,
Hmm. Yes, yes, yes.
right? Second
Yes,
is
yes.
that before hypnotherapy session,
Hmm.
how much in genital or non-genital aspect, how much they were getting, I mean, especially that women were getting sexual containment, at what level?
Sir, actually, I worked with this couple for nearly 20 to 25 sessions, sir.
All right.
25
Yes.
sessions. Actually,
Yes.
this protocol is like this. Say, for
True.
example, the genital sex education related to our genital examination, body
Very true.
examination, all these things step by step. Then I actually see when I am conducting this therapy, I used to call both husband and
Right.
wife. So
Right.
they used to learn all these things. I used to tell all these things, and they used to take it as a homework, and
Right.
they have tried. Then after 2 days, again they will come and report. Yes, yes, we have
Right.
done like this. This is how it was going on.
Right. This is the process. My question is that before hypnotherapy started, how
Hmm.
much how much it was the sexual containment reported by the woman?
It is only 50 to 60%, sir. After the sex education, after the Johnson and
Right.
Masters and Johnson technique, 60% they have attained.
Okay. Before hypnotherapy sessions, you have taken that stage also, these
Yes.
genital containment
Correct.
you have taken. So
Yes.
when you have started hypnotherapy sessions, so what changes did you find that since she already gets sexual containment with genital this containment, genital satisfaction,
Correct.
right?
No. Even during that time, even after attaining 60%,
Huh.
her husband used to say still she is having some difficulty.
In what respect?
In what respect? Means she doesn't like the intimacy. Whenever I am approaching her, she said,
Huh.
no, I am not interested like that.
Right.
This type of process was going on. I used to take a lot of feedback from her husband also.
Right. So can we say that before starting hypnotherapy, she was also having sexual anxiety to have the partner, right?
Correct.
Right.
Yes.
After hypnotherapy, when you have started hypnotherapy sessions, so what was the objective or particular, you could say the short-term goal?
Short-term goal actually, say for example, mainly we have to relax our mind
Right.
and develop by way of giving the different types of suggestions about sexual intercourse. Definitely, it would have worked in her unconscious mind. And definitely, this she would have taken it in a very positive way rather than thinking it as a negative way. This is how
Okay.
I worked out, and based on the literature also, even many review of literature also emphasize the same thing.
Right. Before starting hypnotherapy, clitoral, means this
Clitorius.
clitoral stimulation and
Yeah.
vibration, it was, I mean, applied,
It was applied. It was
and
applied.
it was
It was.
effective in this woman
It
case,
was it
in
was
the index
applied,
case.
but even actually, even in spite of that also, he was having some kind of fear and some kind of hesitation.
Okay, that's good.
Yes.
Acha, second, sir, you have given the protocol of hypnotherapy. Can you
Correct.
show that slide, please? To one thing I wanted to know.
One minute.
It's a very good.
Thank you, sir. Thank you very much for it.
You have mentioned two things.
Sir. This is there.
Right, sir. Number, this one is that 3 and 4, sensory imagery conditioning and dynamic imagery conditioning. I wanted to know about the dynamic imagery conditioning. What was the content of?
Sir, actually, it will this type of suggestion definitely it will help her to elevate her anxiety. It will minimize her anxiety level by way of practicing. See what I used to do after each session. When I am doing this, I used to record it and
Right.
give this audio recorded version to the patient, and I ask her to do it. Ask her to listen whenever it is possible, whenever she is free.
Right.
So
In this
this
dynamic
imagery.
imagery conditioning, only index patient was there, or her partner was also included?
No. This is only for the patient, sir.
Only for the patient.
Only for the patient, not for
Okay.
the this intervention is not for the husband. It is only for the wife.
Nice. Thank you, sir. Sir, one thing it's my just wish, could be possible to get that, I could say the script related to metaphor and all.
Okay.
Sir, that would be very helpful for my cases.
Correct.
Could be possible, sir.
Will try, sir.
It's my request, sir. I want that. Thank you, sir. I know that it would be confidential. I will make it also. If could be possible, please provide that.
Okay.
Thank you, sir. It's
Thank you,
a
sir. Thank
very
you, sir.
nice.
Thank
It's
you
a
very
very
much for your.
enlightening for me
Yes.
to work with the
Sir.
patient, with the problem. Thank you, sir. Thanks a
Sir,
lot.
with respect to this slide on point number 7 and 8, Can you
madam.
throw some light, like what
Which one, madam?
examples of metaphors, Bhavini here?
Right.
The
Yes,
point
madam.
number 7 and 8, sir. The
Eight
metaphors
of
and the
this.
suggestions.
Yeah, this actually this physical intervention is there. Intervention
Yes.
is concerned.
Yes, yes, sir.
Yeah. See, actually, these metaphors are available in this 1 minute. This book. Hammond. If you refer this Hammond book, Hypnosis in Marital and Sex Therapy, Treatment for Inhibited Sexual Desire, Hammond. It is all these
Okay.
things I have taken it from the Hammond. That suggestion, that script is given by the Hammond in this.
Okay.
That script is available in that book.
Just.
Yes.
Yes, so suggestions and metaphors are both from this book, right?
Yes, both.
Okay, sir. Thank you.
So please give me that slide. The protocol of hypnotherapy. Yes, sir. Sir, it's good if we will get the slide of this. Thank you, sir.
Thank you, sir. Thank you very much.
Right.
Your
Thanks a
feedback.
lot. Thanks a lot.
Thank you, sir. Thank you, sir. Thank you. Yeah. Any other?
Anyone else?
Sir,
Sir,
nobody is there. I wanted. Yeah.
Yes, sir. Please, sir. Please, sir.
Sir, Rajiv, sir,
Yeah, but
please unmute
yeah.
yourself. Rajiv, sir.
Yeah. So, very well, huh? Has he unmuted or
No,
Yeah.
sir.
some?
Yeah. We are able to hear you.
I think the way that you can continue. Rajiv, sir,
Yeah.
you unmute yourself, sir.
Rajiv, you are muted. Unmute your, it is muted again.
No. Is it to be muted or unmuted?
You are not able to unmute your microphone.
You have to
Rajiv.
unmute, sir.
No, hello.
He's not audible. He's not.
Sir, I
Hello.
think the headphone is not working, maybe.
Yeah, it is
Talking
not
for-
connect. Not
No,
working.
you are talking for Rajiv sir or for myself?
Rajiv, sir.
Rajiv ke sir.
Is he continuing with something or shall I talk?
I think Rajiv, you may make your audio.
Yes.
Now
You're audible.
Yeah, something wrong with the earphone.
Yes,
Right.
yes, sir.
Santhanam sir,
Sir, yes, sir. Please.
my question is the basic concept of giving a orgasm treatment for a lady or for a man. There should not be any fear of intimacy, because if I'm not wooed by somebody, either by the look or the way the lady behaves or the man behaves, there cannot be sex. In case of masturbation, I sit down and I imagine
Yes.
somebody in my mind, which can be
Correct.
through image, perception, thoughts, and emotions, and I live it in my subconscious mind. So this term fear of intimacy is basically a very loosely used in your presentation. Why? Because intimacy is the basic thing for sex in human beings. So therefore, we should never try to break, we should educate the man and the woman that intimacy is the main thing. Now, in our Indian scenario, like the gentleman was talking to you about, sex education and unlike the Western, kind of knowledge, we don't have it here in our this. It is basically when the man wants, he comes and the woman has to succumb. Whether she's a wife or whether she's a concubine or whatever it is. Now, in case of a disability or in case an orgasm is not being reached, first thing what we should try to educate the person, both the man and the woman, is to become intimate. because the very touch, the very hug, the very, the kind of, this what we give, the strokes, will itself give a kind of orgasm. So this has to be taught. It is not a mechanical process. It is an emotional process. So therefore, intimacy has to be inculcated. Without intimacy, there can never be any sex at all. It is just like going to a prostitute to ease ourselves up or to get ourselves a massage, like you say. The second thing I want to tell you is endocrinopathies. There are a lot of endocrine disorders, which we all have androgens and estrogens within us. Androgens are the male hormones and estrogens, as you know, are the female hormones. So if it is not, and some people who are having, some women who get menstrual disorders and then all this kind of stuff, we got to have this proper history before we delve into this. Post-traumatic stress disorder where there has been rape and use of force, definitely hypnosis will work. And the core element of hypnosis is intimacy. Intimacy, we have to inculcate. We should tell that lady or man not to get scared of intimacy. Even if I'm having an extramarital sex, if somebody says, somebody loves me and she wants me, so we should try to tell them there's nothing wrong in, sex is not something which is prohibited. So the person should not have that fear of intimacy. That is what we should try to say. With these few words, I wanted to know your reaction, sir. You agree with me or not?
Sir, actually, you are able to hear me, sir? These couples, they are basically relatives. They are actually, the man married her own cousin. Okay. And actually, he is very much, what I can say, showing very much love and affection towards this man. He is really loving him. All are psychologically, she is loving him. Actually, all her emotion towards him is okay, perfect. Only during the sexual intercourse is concerned, she is having fear.